Okay, it's your turn. Thoughts, comments, good jokes? How much time do we have, Noel? 20 minutes? Good, okay, so that's what I hoped. So I'm eager to hear comments. Jose looks like he's heading for the barn, for the microphone.
Well, I am very surprised that I didn't hear a lot of disagreement. Programs are fairly complex, principles are fairly simple. Everybody agrees that whether it's a principle or a program, it needs to be very well validated. But some of the questions that arise is that programs typically get tested for their long-term effects, and principles the validation is mostly very short-term. And so the question would be, what are the long-term effects of one of those kernels? But in general, there wasn't any discussion that was true disagreement about whether we should go with programs or principles.
You think we haven't had enough to drink yet?
I'm surprised about that.
Well, I think one thing that was really clear in today's presentation is kind of three levels that people are talking about. One is a level of principles that are kind of like the theory that undergirds the program. Then there's the program, and then there's the kernels or the practices, which are kind of like activities or pieces that might be put together in programs or just done as individual kernels. And I think that distinction between principles and kernels and practices, I think, was a useful distinction here in this panel. Tony, did you have something to say?
Yeah, a couple things. I want to make a distinction between kernels and principles. I think a kernel might be an instantiation of a principle. It's a particular technique for reinforcement of children's behavior is good, okay? Well, here are some specific ways to do it. But I think what you pointed to, Patrick, is the need to get specific about what those principles are. And I would argue that if you look at the family interventions, at least for young children through adolescence, that there are two principles that run through every successful program. And those are that they tend to reduce the amount of coercive interaction between parents and kids, and they use a variety of methods of doing it. Carolyn Webster Stratton has you start by just learning to follow your child's lead, which is minimizing aversive behavior. And so the first one is ways of reducing aversive interactions, and the other is replacing those with a lot of positive reinforcement, and there are quite a variety of ways of doing that. But I think those are two principles that are reasonably well established, and then, but still the issue arises, you go to some community and they say, well, we do those things. It's not a program that, fair enough, but what's your data look like with your kids?
Thanks. Oh, Carol? Carol.
Did you want to say something?
Oh, great, sorry.
Sorry. So take Tony's example, and what gets really important here is whether through the lens one sees the commonality, or whether in fact those are the critical pieces that link all those things. So I'll give you a quick example. I was on a mentoring review panel in 1992 when they were going to put $500 million into mentoring. And so the question became at one point, because somebody was explaining to me how multisystemic therapy was really mentoring, that I said, okay, so what's not mentoring? And to the people in that panel, there was almost nothing that wasn't mentoring. And so the question, that becomes the important point, and actually raised a question that I got very interested in, is, okay, what is mentoring? What makes mentoring distinct? So I think those are where I would like us to get a little more clear. Like, is it coercive, or is it following the lead? Because, for example, the Oregon model would talk about parental reinforcement, not following the kid's lead as a key to what changes behavior.
Well, actually,
Telling you what the Oregon model means.
well, I was going to mention one other thing. I don't know if I'll get a D perhaps in answering your question, but your question was long-term. If you look, for example, at the mediation analysis that Patterson et al. Did on PMTO over 8 years, there are clear relationships between reduction in aversive interactions and certain outcomes and other relationships between the components that had to do with increasing positive reinforcement. So I think there is some things. Now, maybe I've just dodged your question. I don't know.
We can continue later.
So first of all, thank you. That was fascinating scientifically, and this may be rather a dull-witted question, so forgive me, and it may be just that I'm postprandial, and that's why I'm not following. But it seems to me that there's some danger of missing the forest for the trees. I feel like we're almost arguing about how to figure out which of the thousands of chemicals in kale is really good for you versus, eating kale. And if we're about cognitive, affective, and behavioral health in children, I can imagine that multiple programs in teenage pregnancy prevention, drug abuse prevention, teaching social skills, relationship development, healthy sexual development, that these would catalyze each other, that these things would form a whole greater than the sum of the parts. And if we atomize this down to the kernel level to see what components should be into it, we may miss the catalytic sort of interactive effect of an environment that's, broadly speaking, well-informed and healthful in a variety of dimensions. That's not to say we shouldn't do this work, but I am curious how that larger picture would be integrated with the kind of analyses you've been describing.
I'll pick up one thought on this. The work that we do with communities of care, we are helping communities make decisions based on data about what programs address elevated or prevalent risks in that community and protective factors that need to be strengthened. But we also teach people something we call the social development strategy, which is to think in terms of a theory that says what we want to do is create opportunities for active involvement that are developmentally appropriate for kids. We want to make sure they have the skills to do that, and we want to reinforce them in ways that reinforce their effort or improvement or achievement. We think those three things will lead people to feel bonded to the groups that provide those opportunities and reinforcement and skills, and that bonding will in turn provide motivation to live according to the behavioral standards offered by that group. So Communities That Care tries to do both things.
I see.
It's teaching both a theory of behavior that people can use in daily interaction with children, but also increasing the use of programs to fill gaps that reduce risk and enhance protection. So you can do both, I think, in context.
And so in a sense, you're trying to educate parents and people in the community about the things that they need to do. This panel prompted me to have some conversations with Matt Sanders in Triple P, where level 1 is just the massive media communication. And he said they've never evaluated that by itself. They're simply trying to use that to encourage people to do other things. But think about the tobacco control movement. Most of the impact we had on smoking came through mass media and policies that changed as a result of mass media. And I can't help but wonder if we get better and better at communicating to parents the importance of patience and caring and compassion and all the things that are inside all these programs, that we couldn't have an effect simply by changing norms and public understanding. Matt does find that people that he's actually reached directly with levels 2 and level 3, they find other parents who interacted with the people who were reached at those levels who've changed their parenting practices. So I think there are those possibilities, but I completely agree they have to be evaluated.
Oh, I'm sorry, you were next, I think.
Thank you for recognizing me.
Yeah.
Appreciate that. I have a question and a comment. Can anyone on the panel describe the demographics of the community you're referring to or that you work with?
That we personally work with, or
Well,
we're referring to in our talks?
The ones that you're referring to with your slides.
Well, I'm talking about all the communities that have been parts of the research, so it's a very broad group. I don't know.
Very broad, a lot of diversity.
Well, it's diverse, but it's not diverse. So if that's where you're going. There's certainly a very apt criticism. That generalization is probably where we've been least, one of the places we haven't been as careful as we could be and as thoughtful. And there's been a prevailing interest in saying it works for everybody because we find no significant differences by group.
Okay.
I would say that's my assessment of where we are.
Yeah, in our
You know.
experience, I mean, I had both the benefit and the challenge of being located in New York City and doing our work in New York City, where we have a multi-ethnic, multicultural environment. And so in our situation, you really need an intervention that's fairly universal and that's going to work with the broadest range of kids in the population. As someone said earlier this morning, in New York City, they're at least, the kids there are speaking at least 127 different languages. So it's really a broad mix. In other communities, you may have you may have specific populations that for one reason or another are more isolated that you can work with. For example, Native Americans. And then in those cases, it might make sense to, I mean, it does make sense to consider how you can adapt and tailor the interventions to those populations, working with the populations. But in our case, we've not only worked in this sort of multi-ethnic, multicultural environment in New York City, but also have tested interventions specifically on African American youth in one study and in a couple of studies on Hispanic kids. In New York City, mainly Puerto Rican and Cuban kids. But you know, there are differences, but across the board, these interventions seem to be fairly robust and work with a broad range of kids.
Okay, thank you. Dr. Tolan, I want to make a comment regarding your suggestion in terms of looking at the community developing their own program as opposed to saying, here's a program for you, how do we make it work? I think community problems can be solved in the community, and a lot of times they just need some guidance and structure in terms of getting it done. I think one of the reasons why many programs have not worked or had the efficacy that we hope to see is that historically we've been telling the community what their needs are. And giving them little boxes to work within, as opposed to giving them the autonomy to be able to do what's going to work for them, because ultimately they are the experts. And I agree with your last comment on that.
Hi, I'm Kimberly Hoagwood. I'm from New York University and the state of New York, and I want to thank all of you for these incredibly important and interesting and thoughtful comments. I come to this with a somewhat different lens. So we're working right now with all of the child and adolescent mental health serving agencies, providing services in substance abuse, mental health, and health. So it's 850 agencies and agency directors. We're working with about 17 different health plans, and we're working with 3 different state agencies, substance abuse, mental health, and health. And there's a major transformation going on just around Medicaid, around other things too, but I'm just going to focus on that. Medicaid managed care, so that these kids and families, now many millions of them, are going to be coming under Medicaid managed care as of January. And so there's a huge effort right now by states to build into their contracts some specific measures against which they can hold the plans accountable. The plans are looking for measures to be able to say this is what we're going to pay for. And the agencies are looking for ways to respond to this and be able to improve their workforce. So we're talking about a huge population of kids, a major system transformation, and a real opportunity to do not just treatment, but also prevention. I mean, it's really a huge opportunity, bigger than anything I've ever seen. But what I'm trying to do is distill down from what you've been talking about in I think, really important ways. The substance of the evidence is impressive. But how can we distill that down so that I can go back to the states and say to the people at the state level, the agencies and the plans, this is what you ought to be measuring, this is what you ought to be looking for, and it's doable and feasible. So I'm looking for some suggestions beyond the kernels and the principles and programs. What can we actually measure that's going to take advantage of this major system transformation and move things forward?
I'm working with 2 coordinated care organizations in Oregon under a Medicaid waiver. They've created these coordinated care organizations in typically one county, sometimes multiple counties, and they are putting virtually all of their money into treating the people who we fail to prevent these problems. And, you know, Willie Sutton, the famous bank robber, was once asked why he robbed banks. He said, that's where the money is. The Yamhill County, where I'm working, has 25,000 people on the Oregon Health Plan, and they're paying, the CCO is paying for that. Their budget is $100 million a year. And that is one of only 2 CCOs that's putting any money into prevention. The thing that I keep emphasizing is the role of social determinants in the development of the chronic diseases that the medical community is charged with dealing with. And I mean, put aside, we prevented smoking, depression, substance abuse, all of which contribute to those problems. You, in addition, have to be considering the fact that there's significant evidence of inflammatory processes that begin with young children when they're in stressful conditions. These are the reasons why the coordinated care organizations need to be putting a lot more money into these things. The other thing I would say is we've got to get the schools, middle schools and high schools, to systematically do the kind of assessments that communities that care done, or YRBS, or what we've been doing for years, so that the schools and the community has that information. And that's been difficult, and they're not necessarily doing it.
I wasn't clear. Are you asking about what interventions should be paid for, or are you asking about what benchmarks for outcomes? And they're community benchmarks, right, under ACA? Is it
Some of them
population benchmark?
Yes.
Yeah, so they're going to be improvements in major health outcomes, and for mental health, I assume they're going to be mental illnesses, and then some sort of survey stuff around behavior problems and things like that would seem to me to be what would be the key benchmarks.
But what worries me is that the view, at least in the CCOs that I'm talking to, and what I see the healthcare organizations going is, they're talking about what we're going to do when somebody comes to our clinic, what we're going to do to treatment, and they need to be reaching out way beyond that if they want to have the public health impact that they desire.
I think there's some financial incentives, particularly in the, what they call the ones that are for captured populations, those integrated care organizations, accountable care. I think there's incentives there for them to get their costs down over time rather than per person served. So that might be where there's some opportunities for us.
We have limited time here. I think just one other response to that. The question that David Shern asked this morning is the same question. What is it? What are the fundamental things that we should be measuring? You know, one of them is bonding or attachment between children and adults, you know. The level of stress is another one. You know, you can think about these things that we need to be measuring. And again, I think some of them we need to be measuring in the population, which means we've got to be thinking about surveys as part of our data collection system, not just patient records from health visits, but larger surveys that actually get at some of the social determinants that are affecting the health of the population. Tom.
This is Tom Boat from Cincinnati Children's Hospital, and ever since I was on the Preventing MEB Disorders Committee, I have been passionate about doing something about children's cognitive, affective, and behavioral problems. And we deal with this on an everyday basis in pediatrics. I think, though, that I'd like to remind people that, and Dr. Hoagwood and Dr. Kelleher were on this committee, that we learned from a consensus committee that looked at disability due to behavioral disorders, that, you know, the numbers have doubled in the early part of this century. Children on SSI or children who come for behavioral health services who are on Medicaid. Part of it is poverty, but part of it is a lot of other things that we don't fully understand. So Rome is burning in a way. And, you know, I think we have to address the question, how can we do these interventions in such a way that we can learn as quickly as possible what works and what doesn't work? And I'll just cut to the chase. So at Cincinnati Children's Hospital 10 years ago, we made a major effort to embed improvement science. And what we did in almost everything we do in terms of trying to improve outcomes or patient family experience or value is done in that mode. So what you do is set a baseline statistically for what the outcomes are, or the outcomes are at this point, and then you do an intervention. and you should see if it makes a difference. And you learn from that and you make another intervention. And you can keep driving this process down to where the effect size is really very, very great. I'll give you an example. Children were showing up at Cincinnati Children's with congenital hypothyroidism who were initially treated and then lost to follow-up. And some of them were coming back, and they were 6 years of age, and they were this high, and they, had IQs of 20. Unacceptable. So what do? Well, you try to figure out how to, in fact, make sure that these families get back in. This is a behavioral issue. It's it's probably an economic issue. But the point is that the traditional things that people do, flagging the electronic medical record, calling the family, and so on, made a little difference, almost no difference. And it took 5 iterations of interventions to get that number down to 0. We're doing the same thing with primary care in the inner city, but we've introduced behavioral health care at the same level that we do medical care to the children and families there. And we're just following along the social-emotional assessments of those kids. And we can see fairly quickly whether we're making a dent in that or not. The point I want to make is that can we come to grips with things that will allow us to move quickly? I think all of what you're doing is great, but I have an urgency, I think, to push this process along.
Thanks, Tom. Pastor Harris, last comment.
So thanks so much for all of this. It's really been a special treat to be here. And I want to say to the gentleman that got up first, if you're looking for disagreement, start inviting people into this room from urban communities that are really impacted by what we're talking about. From our community and getting into this kind of work, Rodney and I share this belief that our community thinks intervention suggests, let me fix you, while prevention suggests, let me make sure you never get broken. And so I think I do my community and underserved communities a disservice if I don't at least say in this room that real economic investment into communities that need these programs is necessary and even essential. The greatest protective factor is intentional and significant community economic investment. So my question is, once the research is done and once you get all the data, then what? Once you get the facts, what is this room's ask for the communities that you've researched?
Tony? Take it away.
The second half of my book is on capitalism and poverty. I think that one of the things that has concerned me about the prevention science movement is that it has focused much more on programs, and we're going to get those programs out, and those programs are going to make a difference, and that's most of my career, and I believe in those programs, and I promote those programs. But we're going to have a limited impact if we do not reduce the proportion of children who are living in poverty in this country. We have the highest level of child poverty. We also have levels of discrimination that are from my view, much worse than they were 10 or 20 years ago. These are huge stressors, and we need public policies to change that. And we need to look at that larger social system. There is good research being done on policy that could guide us, but we also need to figure out how to evolve a capitalist system that's built on the goal of ensuring the well-being of every person in society, and getting past the view that if I selfishly pursue my own well-being economically, it will benefit everyone. And I say that despite the fact that capitalism has been very good to me.
It's time for us to break it off. We are supposed to come back at 3 o'clock, so I'm going to cut your break a little bit short and ask you to come back at 3 o'clock when there's refreshments out in the hall.